How are you?
I'm fine.
Uh,
Hi, sir.
okay. So, Noel, over the course of next
Yeah,
45 minutes,
yeah,
we are going to go through three case scenarios and certain other
yeah.
questions which will be presented as images to you, right?
Sure. Yeah,
Okay, I'll start, right? Am I audible?
yeah, yeah. I'm much audible. Thank you.
And is my visible?
Yes, slides. It shows GI bleed.
Yeah. Okay, we start. So, this is the first case witness. The
Yeah,
name is John Doe,
yeah,
54-year-old male, chronic alcohol use disorder,
yeah,
liver cirrhosis secondary to hepatitis C.
yeah,
He has had previous episodes of esophageal variceal bleeding. Currently, the medications that he is on is propranolol for portal hypertension, lactulose, and liver.
yeah. So, what is MVI?
That is
Multivitamins.
multivitamin.
Yeah. Okay.
So the presenting complaint is that John presents to emergency department with severe fatigue,
Yeah,
hematemesis, that is he's vomiting blood, and melena, that is black tarry stools, which started off earlier in that day.
yeah,
He reports feeling dizzy and lightheaded, especially when he is standing.
yeah,
Vital signs are BP of 88 by 54 mm of mercury, heart rate of 115 beats per minute,
yeah.
temperature of 98.6 degrees Fahrenheit. His general
Mhm.
appearance is pale, diaphoretic, and he generally appears to be in distress. Abdomen is soft, mildly distended. There are no palpable masses. Hepatomegaly is noted. Neurologically, he's alert and he's responsive, but he still remains slightly confused. So the questions that come through are, what do you think is the diagnosis?
Okay. So, diagnosis-wise, looks like probably this patient is in septic shock. One, he can be an acute and chronic liver disease with a decompensation of the liver function. Two, he can be a spontaneous bacterial peritonitis because of his febrile, his tachycardic, and hypotensive. Three, there is again possibility for hepatorenal syndrome, or if he's having an upper GA bleeding, which is secondary to the cirrhosis as well. And
So
he's in hepatic
what do
encephalopathy because he is quite confused.
uh, how would you define clinically significant bleeding? And what would you how would you define clinically significant bleeding in this particular?
So clinical significant bleeding means that patient has got bleeding with compromise of hemodynamic variables. Patient was very tachycardic and hypotensive, and who is responding to fluids, but there is a need for replacement of the blood. So that is called significant bleeding. Or in volumes, you can say if it is more than 500 ml to 1 liter of blood loss is very significant bleeding.
How would you define treatment failure for an upper GI bleed?
So treatment failure of upper GI bleed is patient who's had a medical therapy and he's escalated to other levels of treatment like endoscopic management, peripheral banding, and there is significant bleeding since even after the management of upper GI bleed with rising urea and significant drop in hemoglobin would define as a treatment failure in upper GI bleed.
So, what do you think are risk factors? Now, we have come to the assumption that this is most likely to be a variceal bleed.
Yeah.
So, what are the risk factors for developing a bad variceal bleed?
So variceal bleeding, the risk factors are your cirrhosis of liver, which gets worsened with the decompensation. But the decompensation can be secondary to any factors like any sepsis or significant um, pre-renal fluid loss. Um there can also be significant portal hypertension, which is going to cause the upper GI bleed. Risk factors are other things, probably any procedures, invasive procedures,
Would
drugs.
you think of any endoscopic appearances, or would you like to think of Any other risk factors which can give rise to a higher amount of bleeding?
So there is a scoring method to understand. There is three grades, one, two, and three. The grade one has got swelling of the or the bulging of the urosephageal varices, but there is no active bleeding. Two has got sorry, one has got nothing, no
Your voice is broken, Noel. Is
significance
your internet connection stable?
of variceal projection.
Noel, your voice is breaking. So is
Yeah,
your internet connection
it's good,
stable?
sir. Is it better?
Okay, this is good. Yeah, this is better.
Okay, let me check.
Can you just repeat the last sentence, whatever you said?
Can you hear me now?
Yeah, this is better.
Okay,
So can you
fine.
repeat
So
the last sentence which you just said?
yeah, so risk factor. So I was telling about the Rockall scoring. In the scoring, we would like to look at the endoscopic visualization where there will be three stages. Grade one, there will be no visible esophageal varices. Two, there will be visible swelling of the esophageal varices, but there is no active bleeding. Three, there will be esophageal varices with active clots. So, which tells you that there's seriously significant bleeding has happened. Other risk factors are even drugs related, patients on anticoagulants, antiplatelets, bleeding disorders. Again, there is again a bigger risk for bleeding as well.
So how would you replace blood products in an upper GI version?
So upper GI bleed, few things. Uh, we'll have to activate a major hemorrhage protocol. We'll have to give some terlipressin from the medical point of view. We'll have to have a target of hemoglobin of more than 7 to make sure that adequate oxygen supply is carried up by the hemoglobin. And there is no much evidence for tranexamic acid in upper GI bleed. So we can use terlipressin, the massive transfusion protocol.
Now, what is the role of lab tests and how would you use your FFPs with reference to lab tests?
The FFP is mainly your clotting factors. So the lab test commonly we use is the coagulation profile. Along with it, we can use the point of care testing as well. So the coagulation profile, you'll be using a PT, APTT, and INR, which can tell you whether the coagulation is prolonged, which is very common in chronically liver failure patient. If the patient is uh, if the INR is quite prolonged, then probably we'll have to replace with FFP. We can also do a TEG in these group of patients, which will tell you about is there any specific issues with just the coagulation factors or the depletion or the problems with the platelets. So based upon that, we can optimize the FFP use.
So when would you like to give antibiotics for in such a
I
patient?
think it is better to give antibiotics early in these group of patients because one, there is a high risk of these group of patients going for a spontaneous bacterial peritonitis. So I think it would be a good idea to start antibiotics. Antibiotics would be a broad spectrum antibiotics would be great. Most commonly, piperacillin tazobactam.
And what are the pharmacological agents which could be used to control or to sort of um, therapeutically ameliorate this varicose bleed?
To ameliorate variceal bleeding, pharmacologically, as I said, we can use terlipressin. Terlipressin is again has got good evidence in improving the outcome of the patients. Uh, we can endoscopically inject adrenaline over the variceal regions, which can help for the vasoconstriction. Um, we can long term in chronically ill patients who's got raised portal hypertension, we can also use beta blockers like propranolol. Um, I think these are the very commonly used drugs.
Okay. So what endoscopic interventions, in your opinion, may need to be done if your bleed is not getting controlled? And what is the timeline or the type of interventions that are likely to be used for this?
So endoscopic procedure. So endoscopic, we can use endoscopic band ligation or clips can be used. Second thing is you can be used for endoscopic injection of adrenaline, which can result in vasoconstriction of the varices. Or we can also use sclerotherapy. which can be very useful as well. Um, and I think these are the most common three types of techniques you can use in the endoscopic method to control the vessel bleeding.
When do you think is tips useful in a variceal bleed?
Tips when we feel these procedures are so when the patient is stabilized, but there is still so like there is still significantly high portal hypertension, then tips will be very useful. Um Most commonly, when there is a hepatorenal syndrome secondary to the liver disease, chronic liver disease, again, tips is very useful in those group of patients as well.
So now we will go on to the next case, Nikhilesh. The specifics we will discuss in the debriefing session.
Okay.
This is the second case. 54-year-old male man with a long-standing history of alcohol use disorder and chronic hepatitis C infection again, diagnosed with cirrhosis 2 years ago and has developed progressive liver dysfunction. His recent symptoms include jaundice, fatigue, and abdominal swelling, which have worsened over the past 2 months. There have been multiple episodes of ascites which have required parasympathetic, and this patient is currently on a low sodium diet and diuretics. To the next slide.
Yeah.
So this guy presents with complaints of decreased urine output over the past 5 days, despite good fluid intake. He is increasingly weak, dizzy, and lightheaded when standing. Denies any history of chest pain or shortness of breath, but does mention working of abdominal discomfort. On examination, he is jaundiced and is visibly emaciated with prominent ascites and peripheral edema. His blood pressure is 90 by 60 of mercury, pulse of 96 beats per minute with a mild orthostatic hypotension. This is his workup. Serum creatinine of 2.4 milligram per deciliter. His baseline was 1 milligram per deciliter 2 months ago. Blood urea nitrogen of 46 milligram per deciliter. Serum sodium of 130 millimoles per liter. Serum potassium of 4 millimoles. LFTs were done, which revealed elevated bilirubin, low albumin, and prolonged INR. There is no significant proteinuria, hematuria, or CAS. Abdominal ultrasound shows an irregularly shrunken liver with no evidence of obstruction, but it does confirm that there is extensive ascites. We do a Doppler ultrasound which shows a patent hepatic and renal vascular. So this sort of covers most of it.
Okay.
So you've
Okay.
heard the case vignette, or do you feel I need to revise it again?
No, 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 I'm fine.
So the questions that are coming out of this is, of course, this looks like HRS. So what are the types of HRS and how would you diagnose this?
Um, so HRS is hepatorenal syndrome. It's type 1 and 2. I think type 1 is rapidly occurring, which has got high mortality, um, which occurs within a span of less than 2 to 4 weeks. HRS type 2 is slow and progressive. Um, how do you diagnose it? There is a clear-cut criteria to diagnose it. There are a few cardinal features. One is your creatinine is more than 133 micromoles with a refractory ascites, but there is no other precipitating factors like infection, and the patient has been adequately volume resuscitated, and no other renal parenchymal problems present. So these are the cardinal features and the way used to diagnose the HRS.
What do you think are factors which can precipitate hepatorenal syndrome in a patient who's already cirrhotic?
The factors are, I would say, infection most commonly. Uh,
What else?
yeah, significant dehydration. Um, Again, that has to be ruled out. Um, I think most commonly it is because of the uh, significant renal vasoconstriction and splenic vasodilatation, which happens in the advanced liver disease.
What you're talking about is factor 50. Any precipitating factor?
Um Infection, hemodynamic instability, any significant dehydration, AKIs, pre-existing AKIs, medications causing AKI.
Such
Uh,
as what medications are you taking?
Most importantly, drugs affecting the kidney function, AC inhibitors, antihypertensives, diuretics, most commonly furosemide. Um
What else?
any stress, any trauma, I'm not sure with that.
What do you think? How would you treat hypertension?
So hepatorenal syndrome as uh, ideally, ABCD assessment and stabilization of the patient. Uh, Most importantly, I think albumin has got a major role. There is great evidence that albumin improves the outcome of hepatorenal syndrome. Um, and adequate fluid resuscitation, make sure that the hydration has been maintained. All the precipitating factors have been removed, like
Is there any
infections.
role
Yeah.
of is there any role of peritoneal venous shunts in hypertension?
Peritoneal venous shunt. I think there is a potentially an effect which would reduce the portal hypertension. So definitely there is a role for portovenous shunt in this hypertension syndrome by reducing the portal hypertension.
We go on to the next case, Vignesh. Will that be fine?
Yeah. Okay. Sorry, I'm not sure with a few questions here.
You're not?
I was not sure with few of the questions in the previous slide.
That's okay. We'll be having a debriefing session. Don't worry about it. You'll get all your answers, whatever I've asked.
Mm.
Right?
Yeah.
Okay. So this is the case Vignesh 3. Right. You've got
Okay.
a 57-year-old man with a 10-year history of liver cirrhosis. So this time I changed the age. It is no longer 54. This guy was older. So 57-year-old man with a 10-year history of liver cirrhosis, secondary to chronic alcohol abuse. He presents to the
Yeah.
emergency department with abdominal pain, fever, and worsening confusion over the past 2 days. His wife reports that he has been more lethargic than and has got a reduced appetite, which is a little bit unusual for him. Some more data in that history. History of cirrhosis
Yeah.
was diagnosed 10 years ago. Multiple admissions for ascites management and occasional hepatic encephalopathy. He reports diffuse abdominal pain, but it's not actually localized, which has been progressively worse. He's got fever with chills, he's got confusion and disorientation, which is of a new onset. There's no history of recent travel, antibiotic use, or surgical procedure. He's been non-compliant with his usual medications, which actually includes spironolactone and furosemide. You are here with me till here?
Yeah. 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 Sir.
So, examination findings. He's febrile, he's got a temperature of 101.3 degrees Fahrenheit, BP of 100 by 60, tachycardic, heart rate of 110, respiratory rate of 22 breaths per minute, SpO2 of 94% on room air. He appears ill and lethargic. There is mild jaundice, abdominal distension with positive shifting dullness, which indicates satiety. There is mild tenderness on palpation without rebound or. Then you've got a neurological exam in which it is revealed that he is disoriented to time and place along with asterixis, which has been observed on clinical examination. There is a mild peripheral. So you absorbed all this?
Yeah.
Okay. So these were the initial labs. You got a
Yeah.
complete blood count wherein WBC is elevated with a left shift. When we did LFTs, you've got elevated AST, ALT, and bilirubin along with decreased albumin. Renal function wise, you've got elevated creatinine levels and serum electrolytes with mild hyponatremia. You've got a PTINR which is prolonged, indicating coagulopathy. And these are the questions. How to diagnose of spontaneous bacterial peritonitis?
So spontaneous bacterial peritonitis, we do an acidic fluid aspirate, and we send for the culture and sensitivity and look for the leukocyte count. Anything more than 250 cells per millimeter cube will be diagnosing that this patient has got a spontaneous bacterial peritonitis.
And when do you decide to give antibiotics in a patient?
So when we see clinically, the patient has got fever, signs of infections like fever and tachycardia, and we suspect in an alcoholic liver disease patient with persisting ascites, I think it's early to start antibiotics. Early antibiotics will be better.
There any specific scores for severity, for labeling severity? And if so, what is the specific score that you're looking
Is it regarding SBP scoring?
for? Correct.
Okay. Not sure with the scoring. I don't have
No
much
issue.
idea on this.
No issue. No issue. If there is a concurrent dysfunction, how would you treat this patient?
So treating with a concurrent renal dysfunction. I think renal dysfunction. The first thing is you treat the infections, hydrate them, treat hypovolemia, avoid any nephrotoxic drugs, and if there is a concurrent renal dysfunction, we have to think about hepatorenal syndrome. And ideally, we once we make sure that hypovolemia is sorted out, sepsis is treated, hypovolemia is resolved, and there is no nephrotoxic drugs. We can also give some albumin, some terlipressin, which will again has got great evidence in improving the outcome.
Now, what is culture negative neutrophilic?
No idea, sir.
Okay. So I go on to the pictorial images. Wait a minute. So this we do like this. We start up from here. Okay. You're able to see, right?
Yes.
Okay. So what drug is this? What is its mechanism of action? And what are the indications and contraindications?
Drug is terlipressin. Mechanism of action is it works on the vasopressin receptors, V1 and V2 receptors, mostly causing the V1 causing the vasoconstriction, and V2 works in the distal renal tubule of the kidney. Indication, we can use it for upper GA bleed, hepatorenal syndrome. Contraindications, we would avoid a patient who's got ischemic heart disease, who's got a significant peripheral vascular disease. We avoid them.
Okay. So what does this image show? What are the indications and contraindications?
So I
Am I
think this is
audible, Noel?
a yeah. I think this is a TIPS, transesophageal, transjugular portosystemic shunt. Indication, contraindication. Indication is patient who's got uh, advanced liver disease with a significantly raised portal hypertension, um, hepatic encephalopathy. We use the TIPS. Contraindication. We usually look for assess the patient for
Your
TIPS,
voice is again
but
breaking
if
up
there
now.
is any kind of anat is that clear?
Yeah, it's better.
Is it better, sir?
Yeah.
Okay. Yeah. So TIPS, we use it. One is for the um upper GI, so significant gastric encephalopathy, or if you have a recurrent or refractory ascites, hepatorenal syndrome, or hepatopulmonary syndrome. Sometimes hepatic failure induced pleural effusion significantly. Um, so these are the commonly used indications we use the TIPS for.
So can you see the drug? Can you identify the drug?
Yeah, it's a cefotaxime.
Okay. What is its indication for use in a chronic liver disease patient?
Um, Taxim is a cephalosporin drug which covers gram positive and gram negative.
Hmm.
Chronic liver failure. Hmm, not sure, sir.
What are the indications? You can look at the image. What are indications for use in a chronic liver disease patient? What are its prerequisites for use? And what are the complications that can arise?
So indications when there is a significant. So this is a things taken like
Correct.
not in, yeah. So it's a things taken like motive. Common indication is upper GI bleeding. Uh, so the prerequisites is uh, a few things is to be done. Patient airway has to be protected. So probably, if possible, endotracheal intubation will be better and ventilation. So we try to check the balloons first. There is one gastric balloon and one esophageal balloon. So which can take up to 500 ml. So we use at least 200 to 300 ml to see whether that is working or not. Um, so ideally, first we have to inflate the gastric balloon, and if that is still not resolving the active bleeding, then we will be involving the inflating the esophageal balloon. Um those are things we need
Complications?
to look for. Complications, most importantly, it can cause, if the pressures are too high, it can cause esophageal perforation, gastric perforation. Still, it can cause significant bleeding, aspiration, and even death.
Okay. So, what does this grading show? And where is it used? What is the significance of this grading? And how would you read the same?
So, so the grading shows different levels of encephalopathy. This is used for hepatic encephalopathy. It's a
Is there
grading
some
system.
name for this grade? No problem. We'll cover that. Go to the next question. What is it?
Not sure with the grading system name, but I know there is four stages of grading system and it's used for hepatic encephalopathy. Uh,
And how would
so,
you treat?
so I think hepatic encephalopathy, we have different strategies. One is we need to use the ammonia lowering strategies, which we use to use enemas and lactulose to open up the bowels. We use L-ornithine, L-aspartate, which is LOLA, branch chain amino acids. Sometimes we also go for renal replacement therapy, which can be also even severe hyperammonemia. We also use some gastric decontamination, which is rifaximin. And sometimes when it is significant, we go for TIPS, like a photosystemic bypass shunt. Um
Okay. We'll go to the next question. What is this test? How is it impacted in kidney disease? And what happens in hepatorenal with this particular?
I think this is a bun creatinine ratio. Um, how is it impacted? This helps us to identify whether it is a pre-renal, renal, or post-renal problem. What else happens in HRS with this? We are able to make sure that the precipitating factors, which is most commonly the hypovolemia, which is a pre-renal, can be sorted out, and any other post-renal problems which can be resolved by relieving the obstruction. If there is a renal impairment, renal parenchyma problem, then we can't grade them as a hepatorenal syndrome patients.
We'll discuss this. Uh, what are the drugs that you can see in this list and how are used in chronic liver disease? What are the indications? What are the contraindications? And when would you like to stop this?
I think most commonly is the beta blockers. The beta blockers, cardioselective and non-cardioselective. I think most commonly used is propranolol. Propranolol, the indication is in severe portal hypertension, and advanced liver disease, helps for preventing the remodeling of the liver as well. Also uses, it helps to reduce the anxiety of the patient. Contraindications when to stop the same. Ideally, if there is any patient who has got advanced liver disease in cardiogenic shock or patient who's got cardiomyopathy, ideally we should hold the beta blockers at this point.
We discussed this as well. Okay. What do you think that this image shows? And where exactly do you think it is used in a patient of chronic liver disease? What are the complications and risks which are associated with the procedure?
I think it's a portosystemic shunting because it is connecting the portal vein to the superior vena cava. In the chronic liver patients, probably if there is a refractory ascites or if there is patients who's got advanced liver disease with high portal hypertension. Complications in discussion with the procedure is one is possible of injury to the blood vessels, portal vein, which can result in significant bleeding and hematoma. Injury to the biliary trunk tree, which can result in a biliary leak um, and peritonitis. Possibility again, chances of sepsis, severe sepsis as well. Um, and so long-term possibly infections again common as well.
So these are three different scores. What are these scores used for? How do they compare with each other in terms of evaluating a liver disease?
I think MELD score is the model for end-stage liver disease. Um, so MELD score is the one which has got sodium in it is in the use. MELD score again can be used for liver transplant as a preparation for the liver transplant, identifying. Child-Pugh score has got 5 variables and it's used in identifying the mortality of liver cirrhosis patient. Cliff SOFA is chronic liver in failure and which is using the SOFA criteria, which helps again to identify the mortality benefit in cirrhotic patients.
So what machine is this? And what are its indications for use in a chronic liver disease?
So this is a CRRT machine. In a chronic liver patient, patient who's got refractory acidosis, patient who's got significant hyperammonemia, which is not managing with medical management, significant electrolyte imbalances with hyperkalemia that can be used. So these are the few indications, or sometimes significant volume overload secondary to liver failure, resulting in significant heart failure, cardiomyopathy can also be used. But the hard indications are refractory acidosis, hyperammonemia, and significant electrolyte imbalances.
This is the last image. What does this image show? And
This,
when is this procedure done in a patient of chronic liver disease?
so this is an endoscopic image which shows the esophageal varices. When it is done, this is done in patient who's got an variceal bleeding. And what type of procedure? I think they're trying to do a banding because I could see a rubber band, yellow color, blue color, the surrounding the variceal swelling.
So that is all for the day, Noel.
Okay,
Right?
yeah, just just a uh,
So
quick
I
question.
guess you are okay.
No, just a quick question. What do you think, sir? What should I do? Focus on? I know I need to brush up few things, which I've got 2 weeks. I'll do on those times. But overall, what do you think? What should I improve on?
See, you know some of these stuff, that is true, but probably you have to be more precise. I'll put it that whenever you answer
Okay,
these questions. That is one thing. Part of these things we would be covering in the debriefing, and there should be certain specific literature thresholds that you should be knowing about. I would cover whatever is relevant to these questions during the debriefing session, so that shouldn't be a source
sure.
of worry, right?
Okay.
Okay.
Thank you, sir.